Hi guys, and welcome back to the Mind the Back chat. Today we are talking about a very popular topic at the moment, which is
repetitive strain injuries.
also known as an RSI. What is an RSI, Gabs?
So an RSI is essentially when there is a continuous load to a specific tissue, i.e. being the tendon itself.
Yep.
So that's the most common one. And when there is that competitive strain, so it could be
competitive.
Repetitive strain.
Competition.
Repetitive strain, what happens is it starts to inflame and get irritated.
Yep.
With that inflammation, it could also give tissue damage around the joint itself where it attaches, so between the tendon and the bone.
Yep.
When that occurs, it starts to get inflammation, and it's just that constant domino effect, which then causes problems with specific movements.
Yep.
What are the three sort of common ones that we always tend to see? Which one would you say?
Well, we'd start off I think in the wrist is quite a common one, especially with more people working at home nowadays, sat at their desk typing or using a mouse, is carpal tunnel syndrome, affecting the wrist. I'd also say rotator cuff injuries, so shoulder strains are very common, especially with people who go to the gym or have a lot of jobs doing overhead work. So actually I think I saw a statistic that over the people who work in car garages over the age of 35, 100% of them had a rotator cuff tear.
100%?
Yeah, so also a thing to remember with rotator cuff tears is though that only a small percentage of those will be causing problems.
Yeah.
Rotator cuffs are one of the most common injuries. I think it makes up 30% of the population has a rotator cuff tear. Tendonitis or something like that.
Yeah,
exactly. It was found that if you're doing overhead work, most people will have those. But the thing is that you can have a tear but not know it's causing a problem.
Yeah.
So you can have a bulging disc in your back, but it may not be causing you any symptoms.
So, you know what, I'm going to comment on both of those little things. So, number one being the whole thing about finding a bulge disc in your spine.
Yeah.
Because with a lot of people that I sort of tend to see in practice, they'll say, I did a X-ray and it showed a herniated disc.
Yep.
And then you start to do a case history and you go, the herniated disc is not the thing that's causing you problems.
Yep.
They just found that. It's a finding, it's a reporting, but it's not a contributing factor. So it's quite important that when we do these X-rays, we don't sort of see causation, but we see correlation potentially.
Yes, exactly that. And I think the statistic is after the age of 40, 85% of the population has a bulging disc, and only 15% of those are actually causing symptoms.
And I think it was 1 in 4, if you look at even before the age of 25, will have some sort of herniation that is minor.
Yeah.
Which is insane. You know, with most people, they go, oh, you're only 25, there's nothing going to be there. No. There probably is. If you do a scan, there is.
By the age of 25, degeneration is already starting your low back. And by degeneration, I mean osteoarthritis, which everyone seems scared of. Osteoarthritis, in a way, is a bit of a repetitive strain as well, and is quite a common one. But just finishing off the topic of which are common, so we did carpal tunnel, rotator cuff tears. I'd also say lateral epicondylitis, also known as tennis elbow.
Yeah, and I think that's so common. With all three, office-based work is going to be a huge one.
Massive.
So going back to, because I said 2 points.
Yes.
My point number 1 was going to be the scan. My point number 2 was actually with people that go to the office and then they go to the gym, what they do is with the office, they're constantly going to be in a sort of internal rotation of
the forearms,
the forearms with
pronation.
Exactly.
Yeah.
And then you're going to have protracted shoulders.
Yeah.
You're going to have chest tightening, chest shortening,
kyphotic curvature.
Exactly. And then they're going to go to the gym where, with a lot of them, they're going to bench incorrectly.
Yes.
So instead of having a extended thoracic spine, which is a mid-back, so extension being looking back and being slightly more bent backwards, they're just going to sit down flat on the bench and then just pump out a couple of reps. What that's going to do is it's just going to cause more and more problems to the rotator cuff, because what it's doing is it's feeding into that positive feedback loop, which then causes problems, and then you get repetitive strain.
And I guess as well, if you're somebody who works from home a lot and maybe you haven't got the best ergonomic setup and you do that day in, day out, multiple hours, and then you go to the gym 4 times a week, max 4 or 5 times a week, and that's only for like maybe 45 to an hour sessions and lifting weights, your muscles are actually more conditioned to being in your office posture, being in that kind of pronated shoulders forward.
Protracted,
Exactly, with weakness in your rhomboids, tightness in your chest and your pecs, strains already going through your rotator cuff. Then you start using them actively and engaging them the way they should be, but they're not conditioned for that. And then that's obviously, as we discussed before, where strains, pains start.
Yeah, and to be honest with you, I think with most people, they're going to find that. And you can't run away from it almost, unless you were to have a good PT.
Unless you have a good PT, Gab's dropping that in again, set up, chest out. Yeah, I'm not gonna lie. It worked. As I said, like I'm now benching 100 kg. After going from like 70, 80 within the space of 2 months.
And it's just a matter of using the correct muscles.
That's it.
But what I meant by actually having a good PT is not a matter of, hey, look at me, I'm so amazing. No, it's got to do with when you train correctly and you train appropriately to the point where actually you can reverse all of these effects of office work.
Yeah.
So a very good example is my partner. They worked in an office for the past 2 years. Office, in living room, and
office in living room.
Well,
sounds like a lovely place to go.
Home working, really.
Home working.
And with them, it was just so easy because what we had to do was strengthen up the back, strengthen up the pecs in a way that is very appropriate and efficient. So showing them how to do it correctly, and then just going from there. And with them, it was so easy because we started to see results very, very quickly. In a matter of, I think, 6 months.
That's really good.
There was a huge change. Not just, physique-wise, but there was also a huge change in regards to what they felt in their back and their shoulders.
Their posture.
Yeah, massively.
Yeah.
So really, it's not a matter of having a PT, but it's having a good PT that knows what is appropriate for you.
Yeah.
Training only becomes effective when it becomes personal.
Wow.
Oh.
How many times have you said that to people?
Quite often, actually, because it's a good one. It's a good one.
It's a great line.
Yeah.
It's like me throwing out movement as medicine as much as I can.
Yeah. And I think it's a great one because it's called personal training, but too many people just do the training part. They forget the personal side of things.
Wow, you are a businessman, aren't you? Look at you.
Calm me.
No, it just got weird.
Oh, no, I did not mean it that way.
No, I'm joking.
For my services as a PT, not for anything else.
But yeah, so going back to, as you said, your partner worked at home for 2 years. A lot of people have been working at home for the last few years, especially the last 3 years with the pandemic and everything. And a lot of people have stuck to that. And I think a lot of businesses have seen financial benefit of people working at home, saving cost on rent in certain offices. But what there has been a lack of is that there's been poor education or transition in ergonomic setups at home. So people having the right information, so not having their laptop at a good height, not having keyboards that have maybe gel pads at the end to soften the blow to the wrist, again a major cause or
factor.
Yeah, predisposing factor to carpal tunnel, having flat mouses as well, repetitive strain, typing a lot, all these things, doing that day in, day out, not having good posture at the desk, all can lead to these issues happening.
So, you know what, let's take it a step back and actually go through what is carpal tunnel? Could you get a bit of an explanation behind that, please?
So, carpal tunnel is a compressive mononeuropathy of the median nerve as it passes through your carpal tunnel in your wrist. So basically, in your wrist, you have a piece of connective tissue that bands across the palmar aspect, so on the palm, and underneath that you have loads of different tendons and also a couple nerves passing through to your hand.
So mononeuropathy being a single nerve and neuropathy being nerve damage.
Yes.
So single nerve damage.
Yeah, exactly. And basically, if you have carpal tunnel, and it's progressive, it can lead to pins and needles in your hand, it can lead to muscle weakness, it can lead to pain, it can lead to inflammation in your wrist, reduced range of movement in your wrist as well. and is just very irritable, basically.
Okay. Yeah.
And this will progressively get worse. You know, most commonly people wake up in the morning and they have all those symptoms in their hands, and it takes time to move around to get it better. And a lot of times it's just due to, again, repetitive strain. So through typing or using a mouse for a prolonged period of time and not giving yourself regular breaks, not giving yourself stretches, movements, and that's the key problem. You normally see it in people aged 45 to 60 because there's going to be a relative bit of wear and tear in there.
Yeah.
But you also see it more in females more than males. But that's also because of other predisposing factors as well.
So number one being hormones. So with females there is a tendency for inflammation and for blood pooling to occur around the wrists. So when you're looking at things like menopause or periods or anything to do with pregnancies as well, you're going to find that you're more predisposed. And just being appropriate with your rehabilitation. So aside from the easy stuff of giving yourself breaks and having the correct equipment, you can also do the reverse side of things. So very good exercises is just simply opening up the palmar surface of your wrist.
Yeah, stretch it back.
So yeah, that's number one. Number two, the same way that you're kind of having this wrist posture where the hands are downwards, why not bring it up and do the complete opposite and then try and stretch it in that upward motion?
Of course.
So what you're doing is, let's say for example, your palm is facing down and then you're bringing your fingers all the way up and just stretching all of that with then the wrist following through with it and just getting that entire anterior stretch, the front side stretch of that palmar surface.
And that's it, giving those little breaks, those little stretches every now and again is going to make such a massive difference as well. And that's the key thing. It's just the body's made to move. If you keep it still in that certain posture and you're engaging those muscles in that certain way for a long period of time, the body's going to regulate that as normal.
But also being patient.
Yeah.
Because RSIs, when it comes to research-based evidence, takes 2 years in order to get fully recovered.
Yes.
Very much like tendinopathies, tendinitis.
Tendinopathy's like 18 months, isn't it, for a tendon to return to normal?
Yeah, but then 2 years is sort of the max level where you're going to find that actually everything is absolutely fine and you're not going to even get that grade 1 damage.
By the way, that sounds terribly terrifying what we just said, like tendinopathies take 18 months and repetitive strains take two years. Obviously the pain's going to be reduced and you're going to be able to function, so don't worry, it's not going to take 2 years of agonizing pain. No, it's unreversible. It's just like if we go into like a microscopic but also, you know, looking through the layers through an MRI, it would take some time. But functional.
Exactly. So you're still going to have everything working correctly in about a couple of months. But if you want to completely and utterly remove it out of, you know, any sort of scan, it's going to have to take around 18 months to 2 years.
So apart from people who work at desk jobs, who else do you quite commonly see get these repetitive strain injuries like carpal tunnel, tennis elbow, those kind of things?
So I think with things like carpal tunnel, I'm going to go with people in manual work.
Okay,
so such as construction.
Okay, yeah.
Number one being a very common one is someone who works with woodwork.
Okay, carpenter.
So a carpenter. Sorry.
Woodwork. It's like saying it's like calling a pilot a plane driver.
Oh my god. Are you speaking
or a book writer?
Is that experience?
I have once said book writer, I think. And somebody's gone, do you mean author? I'm like, that's the one. And then it's always the excuse of, I haven't had my coffee yet.
Shakespeare would be proud of me.
It's dumb.
So dumb that it's brilliant.
No, it's just dumb.
Okay, Benoit.
You know, glass onion.
Woodwork and just using a saw. But with that consistent, repetitive saw work, you're going to find that problems in your elbow, problems in your carpal tunnel are going to start occurring. Because you've got that constant pressure onto that carpal tunnel area, that is then going to get it inflamed.
But you're also engaging those muscles in that compressed area as well, which is going to make that space smaller. And that's what it's all about. It's all about, if you've got inflammation, if you've got tight tendons, it's all about that space where all those tendons and nerves are passing through getting smaller, compressed. you're overusing it, it's going to get tighter and tighter.
And then if you're constantly, for example, using a hammer, you could develop another RSI, which is called colloquially the beer mug RSI.
Beer mug,
brachialis. Brachialis is the other muscle part of the bicep. Mm-hmm. So it's sort of seen as the third bicep, the second bicep, because there are two heads. Okay, I'm not going to confuse people. There are two heads of the bicep, and then there's brachialis, which is seen as the third head of the bicep. So for the matter of how it is, we're going to call it the second bicep. Okay. And very commonly, it's called a beer mug because most people will tend to find that it gets aggravated when they have a pint.
Or
a tea.
Or, I was going to say, in England, it's more the kettle.
Yeah. And they go, oh, whenever I lift up a kettle, it hurts.
That's one of my big telltale signs for lateral epicondylitis.
Yes, yeah.
You know, I people go, oh, yeah, I'm getting pain over here, and I'm like, does it hurt when you pick up a kettle? Yes. And I say to them, like, if you bring your hand back and you put pressure on it, is that painful? Yeah, that hurts. And I'm like, yeah, okay, I think we know. Is it right here? And they go, yeah, that's exactly where it's like. Yeah. It's lateral epicondylitis, tennis elbow.
For me, one of the biggest tests that I sort of do is, okay, put your hand out, and then I will place my finger onto their middle finger, and then I'm just going to ask them to just lift up and go against the resistance of my of my finger, and if that middle finger resistance actually hurts, then I'm like, okay, it's epicondylitis. It's easy.
I went through a period.
Magic.
There's periods in summer where I just see it non-stop. Obviously, people in their gardens, churning up all those weeds, planting all their new flowers in their flower beds, and I'm just like, yep, we've got a bit of lateral epicondylitis here.
And bad knees.
And bad knees, bad backs.
Do you have pads for your knees? Do you put like a little pillow just while you're doing that work? No, I don't need it. Like, well, obviously you do. You're coming in with knee pain. No.
So I guess that brings us on to lateral epicondylitis then, doesn't it? What is it, Gabs?
So lateral epicondylitis is the inflammation of the
common extensor
tendon, but more importantly is extensor carpi radialis. Yeah.
I like how
radialis.
Somebody come check us.
Yeah. Well, I'm sure somebody's going to fact check that. I'm so sorry if that's incorrect.
Radialis, I think it is.
But I remember that being the one. Where essentially it touches onto the common extensor origin, and the reason why it kind of gets very inflamed is because it's a strong muscle, but at the same time it's actually the most common muscle that you use in your entire hand. Because you do have the extensor digitominimi, you've got the extensor pollicis, and then you've got extensor indices. So those are the three kind of muscles that will go to your thumb, your index finger, and your little finger. But then you've got the shared muscle, which is the extensor digitoris longus.
You're really trying to dig yourself into a hole here, aren't you? You're going until you can't go no more, because there's like 23 muscles in your forearm. So
I know, but you know what? I think I'm going in the right direction, in my opinion. I think
you're doing a really good job.
Yeah. Because I'm trying to remember my anatomy.
I'm just waiting for you to get to a point where you're just like
No, because I'm going to stop here. So the shared muscle is the extensor digitorum longus, which is shared between the ring finger and the middle finger. So very much like that little party trick that I said, if you were to put your middle finger curled down onto a table with everything else flat, and you can't really lift up your ring finger without the other fingers being lifted up, that's because they share a muscle compared to your little finger, your index finger, and your thumb being the ones that actually have an independent muscle for themselves.
So basically what we're saying is lateral epicondylitis is due to microtrauma to the tendon or the muscle belly of the extensors in your forearm.
Yes.
Attaching on the lateral aspect, so the outside aspect of your elbow.
Yeah, except very long-winded by my explanation.
Very long-winded. You're giving the people the information, you know. This is a learning process.
Yeah, because what I wanted to do was give an indication that actually every other finger has, aside from the ring and the middle finger, has an extra muscle. So it doesn't have that same amount of strain and so middle finger and the ring finger does.
For sure. Like,
so it's why it's so common for that middle finger to be a aggravating factor for pain to occur with epicondylitis.
That's why when I usually explain it to a patient, I will show them, like, they're like, oh, what is a repetitive strain? I literally just move my fingers and I get them to look at the elbow, look at the attachment site of the muscle, and it looks like almost there's a worm underneath your skin when you do it, but you can see exactly where the muscle's moving, where it attaches, and they go, oh right. And then if you start moving your middle finger, it moves slightly differently. You start using your index finger, another muscle's moving. Use your little finger, another muscle moves. And you put you just stick your thumb on it, and they're like, "Oh my god, that hurts!" And you're like, "You got lateral epicondylitis."
Yeah, because usually it should not hurt.
No.
Like if someone wants to stick their, their thumb and whatever into
yours,
into mine, it's no problem whatsoever.
Yeah.
Whereas with people who have lateral epicondylitis, you touch it and they go, "Oh."
I mean, I've seen cases where people have caught it early. It's quite a quick fix.
Yeah.
But I've also seen people who have left it years and years and years, and it takes a long time to get better.
Patience is key.
There's a lot of different treatment modalities you can go at it with, like soft tissue work, stretches, exercise, strengthening, shockwave therapy, medical acupuncture, dry needling, all this kind of stuff you can go about it with. But the longer you leave these repetitive strains, the longer it's going to take to get better. So you're better off, if you feel like an ache or pain or strain at some point, just get it seen to, or have a look at what's causing it.
Yeah. Because at least once you know what causes it, you can kind of go back on it and go, oh, okay, let me play the sort of investigation game and go, if this is what's causing it, maybe I can just sort of reverse it by not doing that. One of those classic cases of, what causes the pain? When I do this, so stop doing it.
But then this is, again, I've experienced carpal tunnel because we have a job that's very manual.
Yeah.
And I remember waking up several mornings in a row with pins and needles, numbness in my hand that would last 10, 15 minutes. I'm really trying to get rid of it. It was horrible, absolutely horrendous. I was in a lucky position where I knew what it was, but I also was able to go to work, see my colleague and get it treated. And I caught it early on, and within about 2 weeks it was completely gone.
Wow!
Because it was very gentle. It was very light.
So you must have caught it so early.
So I caught, that's what I mean. I caught it very early, but I also know what was another cause of onset. Yes, my job doing that, but at the same time, it was during the pandemic. So I was having to do a lot of home workouts, a lot of push-ups, and I used to have these push-up handlebars, and they had a foam around it, but I'd worn the foam down so much it was just my hand or my palm resting on the metal aspect of it. So I was doing about 100 push-ups a day with my wrist resting on the metal aspect.
I see.
So treatment and removing that
made it go away.
Yeah.
So we have spoken a lot about kind of repetitive strain injuries that are in the upper extremity. Could you give me a couple which are actually found maybe in the lower extremity and just sort of going into that a little bit?
Okay, so I think a very common one would be more your Achilles tendonitis.
Yeah.
Would be a very common one. Again, you actually see a lot of people who work on building sites and stuff like that wearing steel-toed boots that maybe don't rest at the right place for their Achilles tendon. Causes a lot of rubbing over the area, causes repetitive inflammation over time, causes the skin to change. It also causes irritation and damage to the tendon itself, causing strain and a pull. And I saw a lot of that as well. So that's the one I've seen most commonly. Okay, interesting. And also probably with runners, see a lot of runners' knee, iliotibial band syndrome. Again, I'm suffering from it at the moment. And trust me, it's taking a long time to get better.
Painful.
And seriously painful. I couldn't go down like a flight of stairs when it flares up. But
you
again,
can't walk.
I've got my leg band up now, but I've made massive progress in the last couple of months again through treatment, changing my training techniques, building strength in the area, and avoiding what was causing it.
Yeah, and I mean, like, when you do have a flare-up, it looks like I'm watching an episode of RuPaul's Drag Race. You're constantly stumbling around.
Thanks. I'm just auditioning.
It's like hoping for someone to pass by and go,
"You! We need you on TV." It's like, no, I'm injured. No, you're perfect.
You're a drag racer now. Smacking his nose on the microphone.
That was my tooth.
Oh.
I don't know why.
Okay.
I need to change the height of this. Continue.
Swiftly moving on. I think a very common one that we haven't really spoken about, because there's a lot of repetitive strain injuries that come from the tendon or come from ligaments and things like that and connective tissue. You know what? I'm going to throw this out there. Would you say Osgood-Schlatter's disease could be considered a repetitive strain injury? Because
it's commonly found in younger people.
Yep.
Age 12 to 14.
Yep.
16.
Puberty.
Yeah, exactly. There's a lot of growing happening at the time. Also at this point in time, kids are very active, running around a lot. It's the attachment site of your quads in your leg.
Yep.
Coming over your patella, your patella tendon, attaching it to the top of your tibia. And when you're growing, sometimes your bone's growing quicker than your muscles, so that makes it even tighter in the muscle. You're doing a lot of running, it's putting a lot of excess force through the area, it's applying extra pressure to that bone, causing it to become pulled and enlarged. And Gabs, I'm going to let you take away on this one because I know that you've had it.
Yeah, so I've probably got one of the worst Osgood-Schlatter's disease you will find.
We're sounding great right now, aren't we? It's like,
yeah.
I've got runner's knee, this guy's got this, I can't.
But it gives people understanding that actually, we go through all of these. So when you come in and you go, I think I've got this and this and this, and we're like, we've had it. Number one, we've got the knowledge to kind of say whether you have it already regardless.
Yeah.
But because we've had it, we've got the experience of what it's like to have it.
Empathy.
Yeah.
Yeah.
So with my Osgood-Schlatter's disease, it's called a disease, but actually it's completely and utterly benign. It can give pain, it can be very sore. My one was triggered by football. I'm a right-legged football player at the time, so I used to, play football, kick with my right.
Some people say right-footed, but right-legged sounds good.
Yeah, sorry.
Airplane driver.
Arthur. So it used to just cause problems and give me flare-ups, which was absolutely fine, but it meant that I couldn't play football for a long time. And on top of that,
teammates must have been happy.
Yeah, they were. They were like, "He's finally got we can score now." From that, I actually developed Haglund's deformity as well.
Oh wow!
So I've got the double whammy. Not only is it an explanation of what Osgood-Schlatter's disease is. It's when consistent, repetitive pulling of the quadriceps onto the tibial tuberosity of your tibia, which is a shin bone, and the attachment of the quadriceps. What happens is that constant tractioning pull will cause bone to create more bone. With that bonely growth, you're going to have just a huge bump on the attachment of the quadriceps. However, this can also occur with the calf muscles, so the gastrocs. And what it's going to do is going to pull onto the back part of your heel, causing a huge heel spur.
Yes.
Which is called Haglund's deformity. I've got both.
Yeah. Wow.
It's so cool.
Okay, so how did you go about treating that?
How did I go about treating it?
Or managing it, I guess.
Nothing. I just rested.
Yeah.
Rested.
Honestly, because at that point you're growing so much.
I had no clue what I was doing. I don't have the knowledge that I have now. I just kind of thought, it's painful, rest, done.
Stretch.
I didn't stretch.
But this is what I'm saying. This is the information you give out now.
Yeah. The information I give out now is stretch your quads, stretch your calves, do some mobility work, try and strengthen appropriately.
Yeah.
So instead of actually doing football, potentially start off by doing some rehabilitation work whereby the quadriceps are being appropriately strengthened without causing too much damage onto the tibial tuberosity.
That's it. So not a lot of repetitive strain, more
but
managed.
Just appropriate strain.
Yeah, exactly.
Which can then build up to going towards that football,
yeah.
which you can then go to your daily kind of routine again.
Yeah, because conditioning the muscle is what we're looking for here.
Yeah, and I mean, I could show you guys my Osgood-Schlatter's, but I really shouldn't, because then I'm just showing you guys my legs, and no, that's not a good idea. No one wants to see that. So you know what? We're going to leave it for maybe a later episode.
Okay, so we've discussed two of the main, I guess, symptoms of Osgood-Schlatter's disease. One is the attachment of the quadriceps. The other is the repetitive strain injuries. Again, yes, they are more in the upper extremity because, again,
we use our upper extremities a lot more than our lower extremities.
Yeah, exactly, because we use our hands for so much. We pick up things, we type things, we point at things. Use them to grapple onto things as well. But at the same time, we need to talk. We've talked about the most common one in the wrist. We talked about the most common one in the elbow, but the most common one in the shoulder is that rotator cuff that we're telling people about. And a lot of people come in saying like, "Oh, I think I've done my rotator cuff," and I go like, "Which one do you think you've done?" They thought, "Oh, I thought the rotator cuff was just a singular muscle."
It's like, no, there's 4.
And what are those for?
So you've got infraspinatus, supraspinatus, subscapularis, and teres major. Minor.
Thank you. Yeah,
sorry.
Teres minor. I was like,
I went into that way too quick.
Yeah, that was. I like the confidence.
Yeah.
And you corrected yourself. Just took one evil glare from me. You said it, and I was kind of like, I was pretty sure it's minor. So. Teres minor. All the other ones,
So because the major is actually not that important when it comes to shoulder stability, so I should have known that. I'm so sorry.
That's exactly
I'm a failed osteopath.
And that's exactly what the rotator cuff is. It's for stability. It's what actually keeps your shoulder attached to your body. Because if you took all the muscles away from the shoulder, the only thing that's attaching, the only bony connection to your body for your shoulder is your collarbone, your clavicle, at your acromioclavicular joint. But at the AC joint as well is where impingement can happen, or one of the most common tendinopathies of the rotator cuff or strains of the rotator cuff, supraspinatus, which makes up for 45% of all rotator cuff strains, with infraspinatus being 30%, and then the rest divvied out between the subscapularis, teres minor. But also, depending on what muscles become strained, will have a massive effect on your treatment approach as well.
So I'm going to throw this out there as well because...
Throw it out there, bro.
Yeah, because a lot of people, they're going to come in because a lot of people will come in and you can put your thumb over the infraspinatus and the supraspinatus and it will be very, very sore. That does not mean you have an RSI of your rotator cuff. Let's just repeat that right now. You do not have a rotator cuff if it's sore. No, rotator cuff injury if it's sore.
Yeah.
It takes so much more than that.
Yeah, like when you see a true rotator cuff injury, range of movement will be limited, external rotation obviously being one of the main factors. But the amount of times as well I've seen rotator cuff strains and they've said, I think I've got frozen shoulder.
Yeah.
As well. There's a big
difference. Amount of people who I've heard say frozen shoulder, and I'm like, okay, so could you do some lateral abduction of your shoulder blade?
So bring your arm out to the side.
And they'll go like, oh yeah, it can go up to here, but no further. And I'm like, you do not have a frozen shoulder. I'm sorry to say. If you're telling me this happened a week ago, nah. It takes a year, bro. It takes a year.
Yeah, it takes a long 6 months to a year. First phase.
Like
I've known frozen shoulders that can take 3 to 5 years to completely get.
Yeah.
Anyway, sorry, that's off topic. But going back to the rotator cuff strain, so it can be a strain of the tendon itself or the muscle belly.
Interesting. So could you describe to me a little bit about the difference between the two and why would they make such a huge difference?
So basically, muscle has a large blood supply, so therefore it's being brought new nutrients, oxygen, and everything you need for healing to occur. So when you normally look at a muscle injury, you're looking at anything between, depending on what grade it is, a week, let's say, worst case scenario, up to 6 weeks to kind of get better. We're not talking about full tear here, obviously. But the muscle will heal a lot quicker because it's got a larger blood supply. Tendon is a completely different structure to a muscle. It doesn't contract. It doesn't have to use energy to tighten up. It's an anchoring point, so it's very strong. There's a fact. So the IT band is a connective tissue in your leg, and it's so strong that if you attached a Mini Cooper to one end and the other end to the ceiling, you can hang a Mini Cooper off of it and it won't snap. So that's the strength
that
of a tendon.
That has been done before.
So this ain't me making things up. That's fact.
That has been done before, and which brings on to the next point. You cannot roll out, foam roll, whatever you want to say, AITB. It's impossible.
Do your TFL, the one thing that's actually contracting that thing.
Exactly.
Muscles are what make joints move. Tendons are what connects that muscle to that bone, to that joint, to allow it to pull on it.
Yeah.
Hence repetitive strain. So the issue with tendons, if you've done damage to it, is they haven't got a blood supply. Hence why they're white in all the pictures, because they're not being vascularized. Okay, so if you remove blood from the equation, what's bringing that healing nutrients? Yes, they have a very minor blood supply, very minor. And so you remove that blood supply that allows healing. If you've strained it, it's going to take a long time to recover. It can be like, even minor ones can take 6 weeks, up to major ones, as we said, 18 months for it to recover to full.
Really, because what you're going to find is that one of the main sort of supplies for blood to those kind of structures is going to be passively from other structures, such as the fascia. The fascia is probably going to be the one and only kind of connective structure that is going to bring some sort of nutrition and blood into these tendons and ligaments.
Yeah.
Fascia is amazing.
Fascia connects everything. Everything, like, you know, I think we said it before, when you cut a chicken and you can see that thin, almost transparent layer, that's fascia. You have that throughout your whole body, connecting muscles, ligaments, tendons, nerves. It's basically a sheath. It's like a lubrication sheath, so that everything can move together and not get irritated, not get friction.
Cupping is one of the best things for actually separating the fascia from the muscle, so that they start to work independently from each other.
But I can imagine that's great for a rotator cuff strain as well, because you're bringing blood to the area to allow that healing to occur.
So it's one of my favourite things to do. When I do cupping to anyone's shoulder, they come off of it and they go, that feels amazing. I feel like I'm reborn. True comments from people. This is not just me inventing it. True comments. I feel like I'm reborn. It's amazing.
Actually,
you had it done. I did it on you, right?
And I did it on you last week, so we were practicing together. And I strained my infraspinatus.
Yeah.
I think it was more the muscle in this occasion, but very painful. I had Gabs have a look at it, did some cupping on it, did some treatment. I think we even did some dry needling into it as well. Honestly, within a week, I was back to normal. But again, I went to the gym, built up slowly again. So don't ever rush anything back, especially if you've had an injury. But this also brings me just on to something I need to mention to people, because we live in a society where everybody wants a quick fix, and people hear when they get shoulder injuries, oh, my mate had a steroid injection into the area and that'll fix it. Steroid injections, so corticosteroid injections, are there to help reduce inflammation, and that can give you complete relief of pain. 50-50. It potentially can, and if you get one done, make sure it's done under ultrasound so you know exactly where the injection's going. But that injection is there to make you feel better, so that you can do your exercises to rehab the injury, because the injection will only last maybe a few weeks, up to 6 months, up to a year, and if you haven't rehabbed it, the pain probably will likely to come back. I've seen it 100,000 times. The other thing to remember is constant corticosteroid injections into the muscle, into the tendon or the area of damage, will actually cause your tendon to become weaker and cause progressive damage. So you're actually causing worsening to the area.
And more importantly, it could develop into a rupture.
Exactly. And then you'll probably have to look at a more surgical route. And also, if you have a rotator cuff strain or tear of the tendon, do not opt for surgery. A leading shoulder surgeon in the UK, I was at a talk, and he said 90% of his cases that he sees don't actually require surgical intervention or injection. They will always push for manual therapy, exercise rehabilitation first, because if you build up the strength of those muscles, those tone, and support the structure, what are you going to require surgery on? Exactly, and like they even say, like, sometimes, but people won't do that sometimes because they
want the quick fix. They want the quick fix. But actually, to be honest with you, when it comes to surgery, you're probably going to be more debilitated through the surgery than you are from manual therapy, because once you've done the surgery, you're going to have to get it taped, strapped, and cuffed.
Made immobile.
Made sure that it doesn't move. And then from there, you're just going to have to live a couple of weeks without being able to move your shoulder.
Because a patient, even like as young as, I think he was about 24, car accident, broke his shoulder, put it in a cast, came out the cast, hadn't moved it for a few weeks, lost all muscle tone around the area, couldn't even get his arm 10 degrees out by his side or in front of him. And that's just due to complete immobility. And that's how quickly you can lose that muscle strength.
I could never.
It's like, why would you do that to yourself? And that's why nowadays, if you break your wrist and you've got to do in a sling, they tell you you've got to keep your arm moving because muscles will lose strength and tone that quickly.
So you know what? We've spoken about RSIs. We've spoken about the different rehabilitation treatment plans that we can do.
And we've spoken about it passionately.
Very passionately, because fascia is love, fascia is life. That's episode number 8 of Mind the
Live,
Back
laugh,
Chat.
fascia.
So guys, ciao for now.
Ciao for now. Cool.
So
Longest episode that.
I'm gonna keep that high five there.